Hi, all. Thank you so much for joining us for today's webinar on CMS's new access model and the FDA's companion Tempo Pilot program. We are very grateful to be joined by Melissa Wong, who is a partner in the Healthcare and Life Sciences Practice Group of Holland and Knight, based in its Boston office. She focuses on managed care and federal healthcare programs, including Medicare and Medicaid, as well as prescription drug and medical device pricing, coverage, and reimbursement issues. Thank you so much for joining us, and I'll turn it over to you.
Great, thanks, Lydia. Good afternoon, everyone. My name is Melissa Wong. I'm a partner here in Boston at Holland and Knight. I know it is a super busy time of the year right now, so we designed this to be all that you need to know with all the information that we have in 30 minutes or less. So I think we can dive right in. Before I do that, let me share my screen as well, which I forgot to do it ahead of time. So I'll just keep talking and pull up the presentation at the same time. Lydia, I can't remember if I shared it with you in advance. We're also happy to share it after the call if that's available, but I'll try to pull that up. In the meantime, on December 1st, I'm sure you've seen the announcement, but CMS did announce through its CMMI platform that it would be testing an outcome-aligned approach to offer Medicare fee-for-service beneficiaries new options to prevent and manage chronic diseases with technology-supported care. So 4 key things within that really brief description. First, that it is for Medicare fee-for-service. It is not contemplated for Medicare Advantage, although there is a possibility that plans may want to adopt a similar initiative. Second, that it is outcome aligned. So this is kind of continuing the emphasis on value-based care, outcomes-derived payment schedules. Third, preventing and managing chronic diseases. So this is what's really adding to the costs within the Medicare program. And finally, the emphasis on tech, health tech, things that you're all interested in as being part of this organization, kind of looking at opportunities to introduce more technological support for the healthcare that we render in this ecosystem. So let me see if I can share my screen now. Here we go. Hopefully that worked. Now I'm worried that I'll mess it up if I present, but let me try to do that. Is that okay with everyone? Thumbs up? All right, let me assume that that's working. Okay, so the program is going to launch very quickly. It is a 10-year voluntary program. It's also national in scope. It would start on July 1st of next year through June 20th of 2036. So again, a 10-year program. Applications will be submitted starting March 20th, 2026. Now, please keep in mind that elsewhere on the CMS website, it does say April 1st. In the FAQs, it says March 20th, so we would go with the earlier deadline. But importantly, there are different points of entry, so it doesn't have to be all done by March 20th. You can continue to enroll on a rolling basis. You will just have a later start date. Now, CMS identified 4 clinical tracks focused on common chronic conditions. So I've listed them here: early and late cardiometabolic and kidney conditions, musculoskeletal conditions, and behavioral health conditions. So again, these are 4 key drivers of costs within this population. And this to me is the most interesting component. It is direct to consumer in so many ways. So you don't have to go through necessarily a provider to participate in this program. Beneficiaries can enroll directly. They can look up participating organizations or look up the different tools that may be available under this program. Or you can be traditionally referred by your rendering healthcare provider who could refer you to this program.
Your
So,
slides aren't moving. Your slides aren't moving.
oh, they're not showing?
They're showing, they're not moving if you're trying to advance them.
Oh, is it not on the second? How's
No,
that?
it's on the first one.
Oh, okay. Thank you for letting me know. Let me see if I can fix that. Sorry about that. So let me see. You know what? I will work from this, and it might be a little smaller than what you're used to, but hopefully that's okay. How's that?
Yep, it's
Perfect.
going.
That works. Okay. Sorry about that. Okay. So, well, I'm done with this slide, so I'll just move on to the next one then. So based on that, what are participants going to be expected to do? So ultimately, the goal here is to help patients achieve certain outcome-based targets. So like lowering blood pressure. And keep in mind that the participants, it's not going to be just your traditional providers, but it's also going to be potentially manufacturers. So that has some interesting implications as well. But the idea here is you can help patients achieve certain clinical targets, and we'll find out what they are. You will need to be able to electronically share your care plans and updates with the patient's provider at key moments. So when you start and when you finish your treatment, and at certain clinical milestones. And then in order to do this, you do need to be able to integrate with a health information exchange so that the provider can securely access these updates. An important thing here is that you do need to be enrolled as a provider or as a participant in Medicare Part B as either a provider or supplier. So for organizations who aren't used to filling out the 855B, that's going to be a new thing that you'll have to do in order to participate. You'll also have to designate a physician clinical director who will be responsible for care quality and compliance items within the scope of what the participation involves. And you will also have to meet all applicable federal and state requirements. So if you're not usually keeping data or you don't directly deal with PHI, you need to have a HIPAA compliance program. The FDA components, any state licensure components, you'll have to kind of get all that in order in a relatively short amount of time for participation. Ultimately, I wanted to include some segments here as to why it's particularly important to participants today. The examples that CMS had provided on the types of care that we're talking about here, it's integrated tech-supported care. So whether it's clinician consultation, lifestyle and behavioral support, coaching, patient education, care coordination, medication management, and the use of remote patient monitoring or wearables, all of those are suggested items that could be included in this model. Also, CMS makes sure to say that the type of care will include a full range of telehealth and e-health services. So whether that's care provided in person, but also virtually, asynchronously, or through other clinically appropriate methods, all of that will have a role within this new program. Okay. Now let's talk about the money, the payment model. So how will access payment work? Each of those 4 clinical tracks will have guideline-informed, condition-specific measures and outcome targets. What are these targets? We don't know yet. So these are going to be determined, and I think are going to be a crucial piece of all of this. The payment to the participants in the model will be based on a share of patients meeting defined targets versus the minimum thresholds. And that threshold is going to increase each participation year. Now, the organizations themselves can receive outcome-aligned payments made on a recurring basis for the management of a condition. And the full payment will be tied to achieving those targets that we talked about over a given period. So for example, if you're managing a patient with hypertension, you'll get those periodic payments for that management, but the full payment may be tied to reducing blood pressure by a certain extent over a certain period of time. So again, being more outcomes driven. Now, in addition to the payments to the organizations participating in the program, primary care providers, other referring clinicians can also bill for certain services tied to this program, specifically for co-management of the condition, like reviewing updates, care coordination, If there is a need to change or alter or modify a prescription, refer to other providers, or review data and instruct the patient based on those outcomes, that will have a new code associated with it and can be billed as well. CMS did provide what those amounts would be. So they're contemplating $30 per service with some regular geographical and other adjustments. For the initial onboarding, it would be an additional $10 payment. And it would be for once every 4 months per patient per track, with about $100 capped amount a year. So that would be for the referring physicians, or again, the rendering providers who would be kind of co-managing that condition. Another interesting component here is the beneficiary cost sharing. So CMS says right off the bat that participants can forego the collection of beneficiary cost sharing for the outcome aligned payments. You would need to include that in your application that you expect not to collect beneficiary cost sharing, but that would be baked in. And that's, again, totally allowed as long as it applies to all beneficiaries participating in the program. In addition, the physician-driven payments that we just talked about for co-management, there would be no beneficiary cost sharing for those services either. So the last thing I'll mention here is that most of the 4 clinical tracks will include some type of optional continuation period. So the rates are going to be reduced beyond that initial period. And it doesn't apply to deliverables that are supposed to be resolved. But otherwise, the idea is that there could be some continuing payment streams based on the particular track that you're participating in. I'm afraid to touch anything here. I can't see if there's any chats. So, hopefully that worked and I didn't mess up the slides. But let's go on to the next slide on Tempo. So a few days after CMS made the announcement for the ACCESS model, the FDA also announced a corresponding program in alignment with ACCESS, and that is called Tempo, which is essentially a digital health device pilot. So this introduces an FDA discretionary approach to enforcement to support digital health devices that are intended for the use in these 4 chronic conditions identified under the ACCESS model. So the idea here is to encourage the use of this digital technology and allowing manufacturers to collect monitoring and reporting in real time and in real world data that can ultimately be deployed later on as real world evidence for ultimately submission to the FDA for authorization. So this program, this pilot, allows manufacturers to request that the FDA exercise enforcement discretion. And this will usually take the form of, pre-market authorization, or maybe some allowances if it's an investigational device. But you would work with the FDA to identify areas in which you can operate compliantly, at least from the enforcement angle within this program. And they might work with you on the scope of services or use cases, maybe some labeling requirements, or a requirement to maintain certain types of records and data. But ultimately, this is responding to FDA's belief that we need to rapidly look to solutions and adopt some of this technology. And if it's sufficiently low risk to patients in terms of patient safety and harm, that there could be allowances here. So FDA spoke about identifying and selecting 10 manufacturers in each of the 4 clinical areas that are under ACCESS. You could request to participate in this pilot. The way you do so is to email a statement of interest for participation, and that opens in January of 2026. The FDA will send follow-up requests for more information around the March timeframe. They might request information about the product or use, what kind of data that you hope to collect. And the idea here is to also actively engage with the FDA in what they call these sprint discussions to reach mutual agreements within a relatively short time frame. So here, 45 days. So the idea, more collaboration, more direct negotiation with the FDA to allow more rapid adoption of some of these technologies right away. Ultimately, the idea also is to collect that data that can be used by the manufacturer later on in seeking formal authorization. The other thing I'd note here is that this applies whether the manufacturer chooses to enroll and participate in the access model, or if they just offer the device or provide the device to an access participant. So either way, you can leverage participation in this pilot if you are selected. All right, so I wanted to make sure to spend the majority of the time talking about these key considerations. Again, this is such a brand spanking new initiative, and there isn't that much information out there yet. But I wanted to highlight some key considerations here that will truly help drive the success of these programs. So first up, will Medicare beneficiaries be likely to enroll in and adopt tech-enabled care? Traditionally, seniors who are enrolled in Medicare, they might not be as tech savvy. It is an older population. And there is this really heavy direct to patient aspect, which may not exist in other programs. So in Medicare Advantage, you might have brokers. In Medicaid, you might have care navigators. You might have these liaisons who help kind of navigate. And here, there's no real clarity on that. So what is going to be the outreach to patients? Are the participants able to do that kind of outreach? Is it mostly reliant on these referring providers? Are these providers going to be participating as a participant, or will they just refer? Is this going to be driven by vendors? So I think this is a huge thing that we'll have to get across as to whether we'll have the same uplift in participation from this target population itself. Second, the clinical measures and outcome targets themselves, are they going to be achievable? We don't have these yet. All we know is that they're going to be set based on clinical guidelines. But I think we want to be careful of setting too high of a standard that participants may not want to bother. And that is ultimately the real challenge here, is how you manage kind of this goal setting with such a diverse population with these, pretty severe, significant health needs. Third, the payment structure, is that going to be sufficient to incentivize provider participation? The only real numbers we have so far is on the referring provider side. So we're talking about $100 a year per patient per track. Patients can participate in multiple tracks, by the way, but it might affect the cumulative payment. But ultimately, are people going to want to do this and participate it based on the financial incentives? I also wanted to highlight the use of AI-enabled tools. I mean, I don't need to tell you, AI is kind of the name of the game lately in our industry and every industry. I wanted to flag, though, that there are state laws that govern the use of AI in health and health tech. So you'll have to, well, hopefully all vendors are currently considering these implications now. But as these roll out, you still have to comply with these state laws governing AI. Now, I think it was last week that President Trump issued an executive order kind of negating these state AI laws. Jury's still out as to whether that's enforceable and to what extent. But if you do need a little bit of a primer on the use of AI in healthcare, including in digital health, Holland and Knight does make a very cool map available where you can hover on different states and look up the disclosure or the use requirements for states that regulate this type of work. So whether that's disclosure to patients that these tools are utilizing AI, whether it's making sure that the use of AI is deployed in a non-discriminatory manner. These are all considerations that are important with this use of the AI tools. The next item here too, I have seen participants and models just not do well because of the lack of collaboration, engagement, and coordination with the referring provider. So models kind of live and die by the relationship between the participant, the patient, and the PCP in most cases. So our PCP is going to refer patients. Are they going to like the tools and the data and the stream of information to help diagnose? Are they going to use this data in a way that informs the treatment of a patient? Interpret the data, make adjustments to their medication, or follow up. All of this stuff is going to be pretty important, whether it's clinical services provided by the participants themselves, or if you have the referring providers participate actively. There are a few tidbits in the CMS guidance about participants that already participate in another CMMI demonstration model, like the ACOs. This program is designed to be complementary. CMS is assuming no impact to other models for 2026 and 2027, but the expenditures under ACCESS will be counted starting in 2028 for ACO benchmarking purposes. So something else to keep in mind. And finally, I alluded to this before, but this is kind of a new world for a lot of these non-traditional service providers. You could have manufacturers that participate in the health tech space for a long time, but they're not enrolled as Medicare Part B providers and suppliers. Or maybe you have a manufacturer that doesn't have that clinical component, and that might be something appropriate that you want to expand and include. So the idea here is that you do need to be prepared with the administrative requirements of enrollment. If you haven't been billing federal healthcare programs before, you'll want to have a robust healthcare compliance program to ward off any potential risks and liabilities. Any kind of marketing to patients, those communications and what you put out there needs to be carefully vetted, reviewed for any consumer protection issues, beneficiary inducement issues, anything like that. And that's kind of something we want to think about too. This administration believes that the healthcare system and the federal healthcare programs in which it operates in, it's rife with fraud, waste, and abuse. So you want to keep that in mind as you look to launch any of these other initiatives or get into the space, that you do want to be careful and set up the right, really the right infrastructure first before you launch into this. And you do need to do this on a very quick basis because of the timing here. So again, just a quick review of things to think about. I will turn it over to any questions, but ultimately, I do think it is a great opportunity for those who operate in this space. There are some advantages to the fact that this is going to happen now, that the pace here is pretty fast. I think one of the most common complaints about the CMMI models, it's just that you test and evaluate everything over years and years, and people are just like, let's just do it and see what happens. So we want to make sure that this is done in a relatively risk-appropriate manner. And we are still waiting for a lot more info. So that's kind of the downside of this rapid deployment, is that we're still waiting and waiting for information so that we're kind of running the train and building the tracks at the same time. But ultimately, this is a program that I think is very favorable to those who operate in the e-health space. And, hopefully we'll see some really cool new groundbreaking developments. So with that, I'll open it up for questions. I think there's a way to just unmute yourself and participate.
Great, thank you so much. We have a question in the chat. So there's no direct payment for the device or tool itself, correct? Each practice gets a set payment amount that they can then apportion to a tool of their choosing?
Correct. And hi, Nick. Nick's spouse and I work together. She's an excellent healthcare lawyer as well. But that's correct. The payments are going to be based on certain codes that are going to be available for the providers, and for the participants, it will be based on the payment methodologies we talked about. And I'll go back to slide 2. Is that what you were looking for, Simona?
Yes, thank you. It's the one that we didn't see because the slides were not advancing. Thank you.
Oh, sure. Thank you. Sorry about that. Lydia, is there a way to make this available later? I'm happy to share it, or if you want to email me afterward.
Yeah, we can send the slides out to everyone who registered.
Okay, great. So if there are other questions, happy to answer them, or if you want to email me or sync up afterward, I'm happy to be available and I can stay on for a few extra minutes. Um,
I see a question in the chat. Do these outcome-based payments for specific chronic conditions replace fee-for-service reimbursement?
I don't think so. I think they're meant to be complementary. So a lot of that reimbursement is going to be for the rendering providers anyway. So I think this would be for the extra, like the health-enabled care or tech-enabled healthcare that's going to be provided for those particular participants.
I ask, is there any expected kind of standard communication from CMS that you expect to bring us the next round of details around the program, or are we just really in the dark about when the additional details will come out?
There is a way to, I think, submit an interest form so that you can be put on a listserv to get the updates. So that's available on the CMS website. But we'll closely track these, and I'm sure when the information comes out, there'll be a whole slew of alerts and stuff coming out. But I think that's kind of what they're relying on for that direct communication.
Okay.
Question, do you have to use devices or can traditional video visits suffice? It doesn't have to be like a wearable device or remote patient monitoring or other technology. I think the term technology is written quite large to include telehealth, video-enabled technologies, and so forth. And provider type organizations that are eligible, I think it's pretty open as long as you are able to be enrolled as a Medicare Part B supplier or provider. So this includes manufacturers as well, which is interesting. I'd love to see if there's going to be more like JV kind of partnerships between manufacturers and telehealth companies or different arms of an organization kind of banding together to participate. Nick?
Yeah, I think I have two follow-up questions. One is super technical on the access side. So it's my understanding the patients, in terms of outcomes that provider systems will be reimbursed for, are going to be assessed against a baseline. And I think that there's a lot of causal inference analytical work needed associated with that. Is there any inkling of who is going to be doing that causal analytic work? And is there going to be a mechanism similar to the Inflation Reduction Act where provider systems can present their own evidence to show a demonstration of improvements? And I know that that's hyper technical, but then on the tempo side of things, one thing that I've been trying to unpack in this regard is wouldn't a lot of these tools be subject to enforcement discretion already as a type 3 device or not qualifying as a device at all? And so I'm trying to wrap my head around which programs are FDA and CMS trying to target here, and what tools are they specifically looking to exercise enforcement discretion around?
Yeah, both great questions, Nick. I might need to follow up on certain aspects of it, but I'll try to address kind of generally first. My attitude towards kind of the engagement CMS on analytics and data is to I don't think it hurts to engage in some kind of communication or willingness to collaborate and work on informing CMS on certain deliverables in data and analytics. So it's not clear whether they'll accept those comments and kind of that interaction. I know on the FDA side, they're all for it. But in terms of CMS and the setting of those clinical targets, that kind of remains to be seen. I mean, we don't even know what the application really looks like at this point. On the tempo side, I agree with you. I think some of this, depending on the devices that will kind of be utilized in the access model, we are not looking at very, very high level, sophisticated, high acuity devices or devices to treat or to monitor high acuity conditions. So there might be certain allowances already. I think what's significant here is more of the express partnership between CMS and FDA, kind of two sides of the coin. That not just that we're going to do this on the CMS side through Access, which they could have easily done without the Tempo stuff, but to show that this is really more on the tech side, that they want to go in this side by side to try to stimulate this this other push on the health tech front.
Fantastic. Thank you so much.
Sure, thanks. Okay, well, I know we're at time, but again, I'm happy to talk more and keep the group updated on any other developments. But really appreciate all of you joining at during a busy holiday season.
Thank you so much. I think there was a lot of really great information shared, and we really appreciate you taking the time.
Of course, thanks. Take
Yes,
care,
thank you,
everyone.
Melissa. This was excellent. Excellent.
Oh, great, thank you.